as I just started recording this a few slides in, but really we've talked about so far water mass within the human body and the differences between biological men and women. And now we're going to talk about, okay, well, there's about 40 liters of water within you. Where is that 40 liters of water? So the first category is really intracellular fluid. So intracellular fluid is fluid within the cells. Now you have anywhere from 50 to 100 trillion cells within your body. So even though you have anywhere from 50 to 100 trillion little water bags that make you up, because the interior of those cells is so similar, we just lump this into one category. We're not going to worry so much about the difference in water between fat cells and muscle cells and heart cells and skin cells. We just put it in one category. And this really makes up about 2/3 of total body fluid. Okay. The other let's say the other amount of water that was within your body, sorry, I just gotta get my proper tool, is extracellular fluid. So this is any fluid outside of the cells. And we further break this up into interstitial fluid and blood plasma. So interstitial fluid would be fluid that bathes the cells. So you can think of the fluid that's around the cells. And then the blood plasma is basically, think of blood plasma, the liquid part of your blood. And your blood's made up of red blood cells, white blood cells, antibodies, and other proteins. And then you have plasma. And that's the liquid part of your cells. Now, why is it so important? Well, if you think back to week 1 and 2, water is known as the universal solvent. There are so many things that can dissolve in water. And solutes are really substances dissolved in water. So you're going to have two types of solutes. You're going to have non-electrolytes, and these are mostly organic molecules, okay? And they do not dissociate in water. And there are no charged particles. And then your other ones are going to be electrolytes. And you're actually familiar with electrolytes. So think of electrolytes such as sodium, potassium, calcium as some examples. And these do dissociate into ions, and they do conduct electrical current, and they also generate ability to cause fluid shifts. So what does this mean, fluid shifts? Well, this means that depending on the concentration and types of electrolytes you have, so for example, sodium, well, we know that water follows sodium. So if you retain sodium, you retain water. If your body wants to get rid of sodium, it gets rid of water. The water will follow the sodium, and this will cause a fluid shift. That's what we mean by that. Okay, so what are we looking at here? We're looking at a pretty chart. Well, the most abundant solutes within your body are basically, so the most abundant solutes are body fluid electrolytes. Okay, so sodium, potassium, calcium, chloride ions, et cetera. And these will determine most chemical and physical reactions. So the bulk of them will be, of these will be proteins, phospholipids, cholesterol, and triglycerides. And then in terms of this chart, what we're looking at is basically at the bottom, we're looking at the different types of electrolytes. So for example, you see sodium here, Na+, potassium, calcium, magnesium, bicarbonate, chloride, hydrogen phosphate, and sulfate, and then protein anions. And if you think, wow, Matt, it's so good that you're able to remember those all, well, also we can sometimes have little aids such as this legend on the left-hand side. And this is in your textbook on page 1014. The colors represent where these electrolytes and solutes are. So we are going to look at three categories. We see blood plasma is red, interstitial fluid, the fluid around the cells, is blue, and intracellular fluid, the fluid within the cells, is yellow. And so let's concentrate first off on potassium and sodium. So two different electrolytes. We'll draw a line up here. Well, we can see that with sodium, we have quite a high concentration of sodium. So this is milliequivalents per liter. We have over 140 milliequivalents per liter of sodium in the blood plasma, and very close to the interstitial fluid. But in terms of within the cell, we don't have a whole lot. We've got about 10 milliequivalents per liter of sodium within the cell. But think back to a second. Think about excitable tissues, so muscles and neurons. Well, how are these excitable? These are excitable because you have a number of sodium ions outside the cell and very few inside the cell. And you have a number of potassium ions. Well, let's look at potassium. You have a number of potassium ions inside the cell, but not so much outside the cell. Now, the one thing I want you to notice is also on these diagrams is that really, for the most part, blood plasma and interstitial fluid are usually very close. So in this case, we'll see if we can draw here. In this case, in case of chloride ions, pretty close. In terms of hydrogen phosphate, pretty close. Sulfate, pretty close. Magnesium, pretty close. Bicarbonate, pretty close. Calcium, pretty close. So we notice that blood plasma and interstitial fluid are always related. And this is how your body controls electrolyte levels. The plasma membrane of the cell will control the difference between inside the cell and outside the cell. However, the interstitial fluid and the blood will be very close with some exceptions. So you won't have a lot of red blood cells in the interstitial fluid. You won't have a lot of white blood cells in the interstitial fluid, and some other proteins will not be in interstitial fluid because the blood vessel walls, the capillary walls, will prevent those from going into the interstitial fluid. But in terms of your electrolytes and your solutes, those will be very close between the interstitial fluid and the blood. And so if the body, say, wants to get rid of sodium, it's going, I have too much sodium, I need to get rid of sodium, it will dump the sodium from the blood plasma, but then sodium will go from the interstitial fluid to the blood plasma, and you'll have an overall decrease in sodium. So it's good to know that there's that connection. So fluid movement really amongst the different components. So here we see blood plasma. Here we see interstitial fluid. And as we said, these two are very close to each other. And then you have intracellular fluid, so fluid within the cell. So we see that oxygen, and we'll cover this in 2 weeks with respiratory physiology. You breathe in air, and the oxygen will go into the bloodstream, will go into the interstitial fluid, and will go into the cells. And we see that. Now think back to week 3. Carbon dioxide is a byproduct of metabolism. Well, carbon dioxide will build up in the cell, will diffuse into the interstitial fluid, will diffuse into the blood plasma, and will diffuse into the lungs, and you breathe out carbon dioxide. Nutrients is more of a one-way path, right? So, well, a lot of them are one-way paths, let's be honest. Not all of them, but a lot of them. Nutrients, you eat food, gets absorbed into your gastrointestinal tract, and then it goes into the blood, into the interstitial fluid, and then into the cells. Water can pass in between the cells and the interstitial fluid and the blood plasma, and same thing with the at this point at the kidneys. But your kidneys are key organs in maintaining that electrolyte balance. So the purpose of your kidneys is basically they will filter the blood for metabolites, like byproducts of metabolism, results of metabolism, and get rid of them from your body. Or the flip side of that is if your body, say, wants to retain water or wants to retain a certain electrolyte, the kidneys will retain that. So it may filter out some, but then it will reabsorb it, or it won't filter it out in the first place. So the kidneys are key for this. One key thing, nitrogenous waste, so that when we break down, say, proteins, whether it's a disused or a discarded mitochondria that's not functioning, or breaking down proteins for energy, and we want to get rid of the nitrogen, we call that nitrogenous waste, and that will go out via the kidneys, and you pee it out, or the fancy term is micturition. So there you go. There's your $5 word for the day. Yeah, so I think I got everything there that we need to have. Okay. Moving on. So water balance. You take in about 2.5 liters of water every day, and you excrete or get rid of 2.5 liters of water every day. So your water intake, output is about 2,500 milliliters per day, which is equal to 2.5 liters per day. Okay. So where does this come up from? Well, your water intake per day. Well, you're going to drink about 1.5 liters per day. And then you're going to get about 3/4 of a liter, 750 milliliters of water from your foods, and then your metabolism. So again, think back to week 3, the electron transport chain. One of the byproducts of the electron transport chain is water. So your metabolism produces some of the water that you need. In terms of getting rid of the water, you're going to pee out about 1.5 liters. 700 milliliters of it will be insensible loss. And what we need by insensible is you can't detect it. So you do lose water through your skin throughout the day. It's just you don't notice it, but it does happen. You also lose it through your breath. And so a good example is this morning here in this region, we had snow because the temperature was somewhere between 0 degrees and -2 degrees. Well, when it gets that cold, you can actually see the water vapor because, and this is more readily apparent the colder it gets. So if it's -10 or -15 or -20 degrees Celsius, you go outside, you breathe out, and as that water vapor hits the cold, freezing air, it crystallizes immediately, and you can see it as like a fog coming out of your mouth. You will sweat. You'll detect about 200 milliliters of the sweat, and actually about 100 milliliters of this water you will lose through bowel movements, or as my 5-year-old calls it, pooping. You will actually poop it out. Now, these are approximations, right? This isn't, if you're going to say, well, I was reading about, this ultra marathoner who ran 100 kilometers in a race, and that's an ultra marathon, 100 kilometers or more, this doesn't apply to them. They're going to lose more through sweating, but then it depends on the temperature, et cetera, right? So, but this is just in general for the average person. We're not talking about, your ice hockey player who's playing a game of hockey. So you have a term called hang on, I gotta make sure I spell this right, osmolality. And this is really the electrolyte concentration. And your body maintains it around 280 to 300 MOSM. Oops, sorry, MOSM. Okay, so it's just like basically, what is a concentration? So given a volume of fluid, what's the concentration of electrolytes in there. And let's use water just as an example. So in Canada, especially in Ontario, we have a large number of freshwater lakes. And the great thing about Ontario is compared to other places in the world. So I have been to Chandigarh. And I remember when I was in Chandigarh, India, this is northern-ish India, driving past a lake within the city that was a man-made lake, and I could see people paddling boats and canoes out in the lake. And I said to my guide at the time, well, can you go swimming in the lake? And he said, well, you don't really want to. And I said, why is that? And he goes, venomous snakes. Good point. So in Ontario, you can't go swimming in the lakes because the worst thing you run into is a lake trout, and they're quite tasty. But when you go swimming in a lake such as that, that's fresh water. That has a low osmolality. There's not a whole lot of electrolyte concentration in there. If we were to go to a sea or the ocean, the Atlantic Ocean or Indian Ocean or Pacific Ocean, the osmolality is higher, right? That has a higher salt concentration. If we were to go to the Dead Sea, so the Dead Sea is in Palestine, the Jordan River flows into the Dead Sea, but there's no river that flows out of the Dead Sea. That has a very high osmolality. In fact, about 30% of the Dead Sea is salt. In fact, there's such a high salt concentration that nobody can sink in the Dead Sea. The salt concentration is so high, the osmolality is so high that everybody floats in the Dead Sea if you go swimming in there. So let's say your osmolality increases. Okay, so or you have a rise in it. That's being redundant. Well, what happens? You have too high a concentration of electrolytes, so you're going to get thirsty, right? And this causes anti-diuretic hormone to be released. Right? Anti-diuretic hormone. So diuretic, and some of you may be familiar with the diuretic. Maybe you had older family members who have heart disease. They take diuretics because the body's retaining fluid because it shouldn't. That's a whole other conversation we'll get into next week. An anti-diuretic hormone basically causes your body to retain fluids because it's saying per volume, there's too many electrolytes, too many solutes in here. We need to dilute this. We need to have per volume fewer solutes. We're going to retain water to dilute those electrolytes. Now, if you have a decrease in osmolality, then what that does is it causes inhibition. It really causes, ADH, anti-diuretic hormone inhibition. What does this mean? Well, your body stops releasing as much anti-diuretic hormone, and then all of a sudden you're doing the dance because why? You need to go to the bathroom. Your body wants to get rid of water. So if the electrolytes are too diluted, it's saying, well, we want to increase the concentration of electrolytes. We're going to release fluid to increase the concentration of electrolytes. So the body has these processes to help control electrolyte balance. And it looks complicated, but it's actually a beautiful thing. So whenever you look at a diagram such as this, so this is basically page 1017. Let's talk about water, makes me thirsty. Right, your thirst mechanism is driving force for water intake. Okay, and it's governed by the hypothalamic. Now you're familiar with the hypothalamus, the hypothalamic, sorry, it should be thalamic, thirst center. So we have an increase in extracellular osmolality. And think back to about 10 minutes ago. The extracellular fluid, the interstitial fluid, like the extracellular fluid is interstitial fluid and blood volume, blood plasma, right? So they're both linked together. Well, if we have increased osmolality, that means we have an increased concentration within a given volume of the electrolytes, then that will activate the hypothalamus thirst center. So, so these are activated by an increase plasma osmolality T of 1 to 2%. It doesn't take much, it seems, relatively, right? Also, they are activated by dry mouth. They're also activated by decreased blood pressure or volume. So we think about this. If you have, say, 6 liters of blood or 5 liters of blood, and that goes down, which will cause a decrease in blood pressure, that's a mechanism or a signal for your body to say you need to get more fluid in you. So you drink more water, okay? And then one thing that is also a bit more technical is angiotensin 2 or baroreceptor input. Baro means pressure. You have these baroreceptors. A baroreceptor is a pressure detector within your body. And if it detects that blood pressure, blood volume is going down, the pressure is going down, then this will activate your hypothalamus thirst center, which will cause you to want to drink. And of course, drinking of water inhibits the thirst center, as it should, okay? And then your inhibitory feedback signals include, right, well, this one makes sense, relief of dry mouth, and also activation of stomach and intestinal stretch receptors. So let's go through this bit by bit, because we should, and you need to understand this. I don't want you to look at this diagram and be like, ah, I want you to look at this diagram and go, but it's not so bad, it can handle this. ECF, extracellular fluid. So this is the fluid, the interstitial fluid around your cells. This is the fluid within your blood plasma. We see an increase in osmolality, increase in intracellular osmolality. That means the fluid around the cells and the fluid in your blood per given volume has more solutes, more stuff dissolved in it. So this will activate the osmoreceptors in the hypothalamus. And also you're going to have decreased saliva and you're going to get a dry mouth. So we'll just follow these two pathways, which lead here to the hypothalamus thirst center. Another possible signal, decreased plasma volume, right? So remember, that's different than osmolality. Decreased plasma volume, your blood volume has gone down 5 to 10%, which leads to a decrease in blood pressure, which activates these cells within the kidney, which activates the renin-angiotensin-aldosterone mechanism, which basically just says, hey, we need to pump out more angiotensin. But if you have these osmoreceptors in the hypothalamus activated, you have decreased saliva and a dry mouth. And if you have increased angiotensin 2, this all leads to your thirst center being activated. Now you're thirsty. You want to take a drink. Well, you take a drink, the water moistens the mouth and the throat, stretches the stomach and intestines, and you have water absorbed from the gastrointestinal tract, and that leads to a decrease in extracellular osmolality. Decrease in the fluid around the cells in the blood means that per volume, you have fewer dissolved substances, and we increase the blood plasma volume, and then that will inhibit the hypothalamic thirst center. So there's a lot of steps, but the good thing is they should be clear. And if they're not clear, don't feel bad. It's just you need to look at this a few times to ensure that it is clear. Another way, it could be ugly diagram, but it's not. So we're going to give you some additional text first, and then we'll break down this flow chart. So obligatory water loss really explains why we cannot live without water very long. Okay. You can go 3, maybe 4 days without water and then you die. People call it rules of threes or rules of fours. 3 minutes without oxygen, 3 days without water, 3 weeks without food, or 4 minutes, 4 days, 4 weeks, depending on, I guess, how tough you are. Really, so insensible water loss, you're going to have insensible water loss from the skin. from the lungs and from, as my 5-year-old calls it, poop. And then you also have sensible water loss from urine, right? And so your minimum daily loss, even though we said it is, 2.5 liters, your minimum daily loss is going to be 500 milliliters. Now keep in mind, as the body detects that it's losing water, it's going to try to retain water. So the urine volume excreted and the solute concentration depends on fluid intake, right? Diet and water loss by other avenues, okay? So how much you lose, really, it depends on how much you're taking in, what you're eating, where else you're losing water, right? So if you're exercising in a hot and humid environment, so we're talking 50 degrees Celsius with 100% humidity, you're going to lose a lot more water. And then we'll get into that later. So water reabsorption in the collecting ducts. So this is, to learn how to type, Matt. Is proportional to ADH release, ADH being antidiuretic hormone, right? So you release more antidiuretic hormone, you're going to reabsorb more water, right? If we don't have as much antidiuretic hormone, your urine is going to be a lot more dilute. It's going to be lighter in color, right? If we have increased antidiuretic hormone, we're going to have concentrated urine, right? Sorry, with decreased antidiuretic hormone, you pee out more. You release body fluids. With increased antidiuretic hormone, you retain more of the fluids. So if you have increased antidiuretic hormone, your urine will be darker in color, okay? Your hypothalamic osmoreceptors will sense extracellular fluid solute concentration and regulate ADH accordingly, okay? So these receptors, osmoreceptors means osmolality. So they actually will detect the concentration of electrolytes and solutes in the fluid, in the extracellular fluid, and then will regulate antidiuretic hormone accordingly. So think about the chain. If you have an increase in extracellular osmolality, which means increased concentration of solutes that are dissolved, then basically you will hold back ADH, antidiuretic hormone, which means you'll release fluids out of the body. If you have a dilution of osmolality, decreased number of solutes per given volume within the body, you will increase antidiuretic hormone and hold back some of the fluids to help concentrate that, okay? And then other factors that can affect this, well, you may get large changes in blood volume or pressure, okay? So if you have a decrease in blood volume, you're going to release more antidiuretic hormone to retain fluids, right? So a decreased blood pressure will cause increased antidiuretic hormone, which will cause increased retention. Decreased blood pressure volume also could be caused by intense sweating, so exercising in a hot, humid environment, vomiting, so if you have a stomach bug, diarrhea, right? So, and this is a primary concern for people who get, say, these major diseases. I'm trying to think of diphtheria, in developing nations that because they can't retain any of the fluids, they will actually put saline solution directly into their blood to help maintain their fluid volume. You may have severe blood loss, so I think traumatic injury, also traumatic burns. So if you have third-degree burns on the skin or worse, you can actually lose fluids from where the skin used to be. And also a prolonged fever, because if you have a prolonged fever, you're going to be sweating a lot. And so that can also be a cause for fluid loss. Okay, so moving on. So, I mean, disorders of water balance. So here on the very top, we can see dehydration. And dehydration is basically the extracellular loss or extracellular fluid loss is due to one of many types of events. And in this case, it shows you that this individual is exercising in a hot environment, maybe not necessarily humid. And humidity makes a difference. So I've been both in New Delhi and Chandigarh in India in August when it's hot and humid. I've also been in Las Vegas, both in July and May when it was just hot, but not humid. So Las Vegas, Nevada is in a desert. It can be 40 degrees Celsius or hotter, but it's not very humid. It's very dry. Whereas in Chandigarh and New Delhi, I remember in New Delhi, my one tour guide who was not native to India, but had been there for 3 years, and his comment was, "This is the hottest and most humid it's been in my time here," right to the point where people could potentially die. That's how hot it could be, and it's more indoors, but that's a whole different conversation. But in this case, we see an individual who's exercising in a hot environment. Well, they have excessive sweating. They have an excessive loss of water. So they're losing body water through the sweat. Now, because the extracellular fluid is losing water, the intracellular fluid will lose water. So in this case, what is happening? Well, we see that the extracellular fluid, so that's both blood and the interstitial fluid around the cells, we see an increase osmolality. Osmolality. Okay, so per volume, you have more electrolytes. And the body, basically through osmosis, wants to equalize that, so you will lose water from the cells. The cells will actually shrink because of that. Now, that's dehydration. The second series of images at the bottom is basically hypotonic hydration. So in this case, this person is in the shade, they're sitting down, they're not exercising, and they're consuming an excessive amount of water. Well, you have an excessive amount of water enters the extracellular fluid, and in this case, in that extracellular fluid, in the blood, in the interstitial fluid around the cells, we see a decrease osmolality. Right? So given a volume, the amount of electrolytes and solutes is decreased. Actually, sorry, I just realized I spelled that wrong. Osmolality. So in this case, we see that per volume, the number of electrolytes is decreased. And again, the body wants to equalize this, so it shifts water into the cells. Through osmosis, water goes into the cells. Water, if it can go through a barrier, will go in the direction to make sure that on either side of the barrier, the electrolyte and solute concentration is the same. So in this case, it's the cell membrane. Water can move freely in and out of the cell membrane. So in the first example, they're exercising in a hot environment. Water leaves the cell to try and decrease the osmolality. In the second example, water enters the cell in order to increase the osmolality. So those are two examples. And this actually, you may think, well, come on, could this actually happen to the point where it's endangering somebody? And yeah, it actually can. So I'm going to give you a story. It happened about 10 years ago when the Nintendo Wii was a very popular gaming system, if you can think back that far. There was a competition at a radio station in Florida in the United States, and the name of the competition was Hold Your Wii for a Wii. So the idea was these contestants would drink a given sample of water every 15 minutes, and the person to go the longest without going to the washroom won the Nintendo Wii. So this woman won, and she went the longest without going to the bathroom. And when she was the winner, they said, okay, you can go to the bathroom. And she's like, well, I don't want to go to the bathroom. Like, now is a challenge. How long can I go without going to the bathroom? And so she went home and still didn't pee, and then she died. Well, what happened was she had so much water in her system that those electrolytes and those solutes became so diluted that her body couldn't function anymore. And she basically died of sudden cardiac arrest. Like, her heart just stopped. So not a good option. Now, we've talked about dehydration, we talked about hypotonic hydration. There is a third issue, and that is edema. So edema, here's your definition. Atypical accumulation of interstitial fluid, okay, resulting in tissue swelling. And this is not cell swelling. Okay. So only the interstitial fluid volume is increased and not of other compartments. You may have actually seen this in most likely someone who's elderly. When you think of an elderly uncle or auntie, a grandparent or great grandparent. And really what can happen with this is this can impair tissue function by increasing the distance for diffusion of oxygen and nutrients from blood to cells. And it could be caused by an increased fluid flow out of the blood or a decreased return of fluid to the blood. Most often you'll see edema in heart patients, and we'll get into that next week. But a quick summary of why you may get edema in heart patients is, for some reason, the heart may start to fail. It's not ejecting as much blood. It's not pumping as much blood to the body as it should. So the body thinks, I know what I'll do. I will increase the blood volume. So it retains fluids to increase blood volume, and then now the heart is pumping out enough blood to meet the metabolic needs of the body. But when you increase the volume of blood, you increase the volume of interstitial fluid, and it becomes a cycle. But we're going to get more into that next week. Okay, so at this point, we were at 2:53. We're going to give you a 10-minute break again. And you have various disorders of water balance. We saw dehydration, hypotonic hydration, like too much water, and then edema, which is another one that can be an issue. And we'll talk more about edema next week when we talk about the cardiovascular system, that is the heart and the blood vessels, in terms of what's wrong with that and why there are problems. Okay, so we talk about sodium, potassium, calcium, phosphate level regulation. So the body needs to control the concentration of these electrolytes within the fluid balance. And it's funny because we haven't really gotten to acid base, but we'll get there eventually. So we have calcium, Ca, magnesium is 1 mg, potassium, K, sodium, Na, and what else? Phosphate, pH. So really, when we're talking about electrolyte balance, we're usually only talking about salt balance. Okay, and it also can include acids, bases, and some proteins. Okay, so salts will control fluid movement. Okay, the salts will provide, and salts will dissociate. So a good example is to think of table salt. Table salt will have sodium chloride. It's sodium chloride, and when you put it into water, it dissociates into sodium ions and chloride ions. Sodium ions being positive because they lose an electron, chloride ions being negative because they gain an electron. So salts will control the movement of fluids in the body and out of the body and back into the body. And the salts will provide minerals for excitability. So we talk about excitability, we talk about an action potential in a neuron or a muscle cell with an action potential and then being able to contract. Secretory activity. Think of fluids, exocrine glands, right? So sweat, saliva, etc. And membrane permeability. Salts enter the body via ingestion, so you consume them, and metabolism, you break them down, and they are lost by or via perspiration, sweating, feces, as my 5-year-old calls it, pooping, urine, peeing, and vomiting if you happen to do that. And this vomiting can be a concern because if somebody is ill, either think about either diarrhea or vomiting, and they are losing electrolytes, then that may be where you want to have an electrolyte replacement. So, for example, in pediatric cases, so children, there's something called Pedialyte, which is an electrolyte balanced flavored drink specifically for children. And if you're an adult, you can think of something such as Gatorade. Gatorade being one famous example. And my personal preference is Gatorade over Powerade because Gatorade has less sugar. It's actually right at the ideal electrolyte glucose balance for ideal absorption and most efficient absorption of those electrolytes. So if you are sick and you're vomiting or you have diarrhea, then you may need to consider if you can keep it down to consume some Gatorade to help replace those electrolytes. Or as soon as you're able to tolerate, start drinking fluids. Your grandmother was correct. Once you can hold it down, start drinking fluids. So this is really just causes and consequences of electrolyte balance. And looking at this going, goodness, what is this all about? Well, it's not really that scary. I'm going to take away my annotation table for a second. We have the ion here on the left-hand side. So we have sodium, potassium, phosphate, and then this is a continuation of that table, chloride, calcium, magnesium. Here we see the abnormality. So you can guess based on this that sodium should be between 135 to 145 milliequivalents per liter. Well, so think hyperactive, like, you know, the kid that you just took to McDonald's and fed him a bunch of sugar and 3 Red Bulls, hyperactive. Hypernatremia, too much sodium, is going to be anything above 145 milliliter equivalents per liter. And yes, you do need to be able to recognize, like if I threw out, hey, what's hypernatremia? 145, 135, 150, you need to recognize that anything above 145 is hypernatremia. You have hyponatremia, like hypotonic, like slow, is below 135 milliequivalents per liter. For potassium, you have the same things, phosphate, chloride, calcium, magnesium. You have possible causes, and there's a number of causes for these. So hypernatremia. Now, what I don't want you to do is don't just memorize this, but understand why. Okay, if you're dehydrated, why would you have hypernatremia, like too high a concentration of sodium? Well, if you've lost fluids, you don't have as much fluid to dilute the sodium. So the sodium becomes more concentrated. You get hypernatremia. What happens? The consequences. What is an outcome of hypernatremia? Well, first off, you're going to be thirsty, right? And central nervous system will detect this. It'll activate the thirst centers in the hypothalamic center in your brain. And it could then, if it's really bad enough, lead to confusion, lead to lethargy, right? You're slow, you're tired, possibly to coma, right? You may have neuromuscular irritability. What does this mean? Well, you're going to have muscle spasms, convulsions, twitching. This chart goes through all of these ions. What happens if you have too many, too little? What are the levels? What are the possible causes? What are the consequences? And so really for studying purposes, you do need to review this and be able to recognize, if you're given different options, you need to be able to recognize, oh, that is hypernatremia. We have above 145 milliequivalents per liter, and this is a cause. Really, sodium has a central role in fluid and electrolyte balance. And where the sodium goes, fluid goes. So we're going to go back to our annotation. So sodium that leaks into cells is pumped out against its electrochemical gradient. Okay, so even though there's most sodium outside the cell and it leaks into the cell, it's going to get pumped back out. And it moves back and forth between the extracellular fluid and body secretions. Okay, so sodium will go from extracellular fluid to body secretions and back to extracellular fluid. Now, you do need to be aware of sodium concentration versus sodium content. Okay, so there's a concentration of sodium, like per given volume, how much sodium do you have in your body versus how much sodium do you have in the body, full stop, regardless of concentration. Okay, so for concentration, okay, this determines osmolality of extracellular fluid and influences excitability of neurons and muscles. So the concentration of sodium, right, that makes sense. Osmolality is basically the concentration of electrolytes and solutes in the fluid. So concentration of sodium affects osmolality. That makes sense. Also will affect the excitability of neurons and muscles. Well, that makes sense because sodium is involved in the excitability of neurons and muscles. Content, total body content, determines extracellular fluid volume and therefore blood pressure. So if we have more sodium in our body, we retain more fluids, your blood volume goes up, your blood pressure goes up. If we get rid of sodium within the body, then we get rid of fluids and our blood pressure comes down and our blood volume comes down. There are no known receptors that, oops, I'm running off the screen there, sorry. No known receptors that monitor sodium levels in body fluids. Okay, but sodium water balance is linked to blood pressure and blood volume control mechanisms. So what does this mean? It means in your body, you don't have anything directly that measures how much sodium you have in your body. But because it's linked to blood pressure and blood volume, we can measure, the body can measure blood or monitor blood pressure and blood volume and then adjust according to blood pressure and volume. Really, what this means is changes in blood pressure or volume trigger neural and hormonal controls that regulate sodium content. Blood pressure goes up, too high, body gets rid of sodium to get rid of water. blood pressure goes down too low, the body retains sodium to retain, or retains water to retain sodium to retain water, sorry. And really what this table is telling us is we have extracellular concentration and body sodium content. And we measure sodium concentration through the osmolality with osmoreceptors, and then you have antidiuretic hormone or thirst mechanisms, and we measure content through blood pressure and blood volume, which are pressure receptors, baroreceptors, and that's that whole renin, angiotensin, aldosterone, and AMP hormone mechanisms. So that's basically how we're controlling sodium content and concentration within the body. So this is where it gets a little bit more complicated. But we're looking at basically the influence of angiotensin and aldosterone within the human body. Okay, so aldosterone plays the biggest role in the regulation of sodium by the kidneys. We're back to the kidneys. The kidneys will release or retain sodium as needed by the body. So regardless of aldosterone, like regardless of whether you have it there or not, 65% of sodium is reabsorbed and 25% is reclaimed. So you have these different components of the kidneys. And we're not going into the microanatomy of the kidneys, but 65% is absorbed in the proximal tubules, 25% is reclaimed in the nephron loops. So basically, when aldosterone concentrations are high, sodium is actively reabsorbed, and the water follows that, right? So if we release aldosterone, we reabsorb sodium, we reabsorb water, extracellular fluid goes up. When aldosterone concentrations are low, we don't reabsorb as much sodium, and we lose it to the urine, and you also lose water to the urine. The renin, angiotensin, aldosterone mechanism is the main trigger for aldosterone release. So you are going to have these cells which secrete renin, the substance, in response to sympathetic nervous system stimulation, to decrease sodium chloride concentration, to decrease stretch of the cells because they have lower blood pressure. Renin will help promote the production of angiotensin 2. This will release aldosterone from the adrenal cortex, that's on top of the kidneys, and results in increased sodium reabsorption, increased water retention. Aldosterone release is also triggered if you have elevated potassium levels in the extracellular fluid. But when you release aldosterone, this takes days or hours to affect. And this is one of the reasons why if you have exercise in a hot, humid environment, you want to give your body time to recover the fluid balance, okay? So following the chart here, we see a decrease in body sodium content, which triggers the release of renin, which increases angiotensin 2. We see an increase in potassium concentration in extracellular fluid. Either way, we're going to stimulate the adrenal cortex to release aldosterone, has an effect on the kidney tubules. When you release aldosterone, you reabsorb more sodium and you secrete more potassium, and then you retain more water, and that will restore hopefully the balance of sodium and potassium. And if you thought that was a bit messy, oh, you're gonna love this one. This one's awesome. Right, look at that. Woo. Your heart's also involved in this. We have this atrial natriuretic peptide, ANP, right? See it right there at the top, atrial natriuretic peptide. Well, you have baroreceptors within the aorta, the major blood vessel that comes out of the heart, and within the atria, okay? So these atrial cells get stretched. If you have increased blood volume, increased blood pressure, the atria and the heart get stretched. Those are the top two chambers of the heart. And what does that happen? Well, we want to get a decrease in blood pressure and blood volume, an increase in antidiuretic hormone, renin, and aldosterone production, increase excretion of sodium and water, and promote vasodilation, right? The capillaries, the smaller blood vessels can either open up, dilate, or constrict, close down. So ANP is released. Well, it has all these effects. And if you're looking at something like this, we want a sense of it. Well, just follow one pathway at a time. Let's make sure we have the proper tool. So ANP has an effect on the adrenal cortex, decreases aldosterone, inhibits the collecting ducts. What happens? We see a decrease in sodium and water reabsorption, a decrease in blood volume, a decrease in blood pressure, decrease in stretch. It also affects the hypothalamus and pituitary gland, decreases antidiuretic hormone, which has an effect on the kidneys, which decreases sodium and water reabsorption, decreased blood volume, decreased blood pressure. And AMP also has an effect on these specific cells in the kidney, decreases renin release, decreases angiotensin II. You get opening up of blood vessels, decrease in blood pressure. So the whole point is we want to decrease the pressure. But we do see that with chronic heart patients, there can be basically issues with how the system functions. It misreads the function, and short term is a gain, long term is a loss. And if you thought you loved that one, you're going to love this one. This one's awesome. Look at this. Fantastic. So the influence of other hormones, right? So if we see a decrease in blood pressure or volume, well, again, follow one pathway at a time. It affects the posterior pituitary, which releases antidiuretic hormone, which has an effect on the kidneys, which causes an increase in retaining water, increased blood volume, increased blood pressure. We see it start at the top again, a decrease in blood pressure volume. It inhibits the baroreceptors, has an effect on the sympathetic nervous system, has an effect on the arterioles. They constrict, increases the resistance, because if the blood vessels close, it's more resistance to the heart pumping, which increases blood pressure. Again, in the middle and to the left, it decreases the concentration in the kidneys of sodium chloride, and it decreases stretch in the arterioles. So this is from a decrease in blood pressure. Has an effect on the cells of the kidneys, has an effect on renin, which converts angiotensinogen to angiotensin 1 to angiotensin 2, has an effect on the adrenal cortex and systemic arteries, leads to vasoconstriction, increased peripheral resistance, increased blood pressure, has an effect also on the adrenal cortex, releases aldosterone, has an effect on the kidney. We reabsorb more salt and water, increase blood volume, increase blood pressure, but the whole point is we're trying to increase blood pressure at the end of it. So there's quite a few things that can have quite a few effects on this. And you'll have these baroreceptors, these pressure receptors. So the body, even though, so for those of you who were in the lab yesterday on Monday, and for those of you later on in the lab, we're going to talk about measuring blood pressure. We ourselves can't detect changes in blood pressure, but the body can. So it's not like you're like getting a, most people, it's not like you get a shoulder pain because they have increased blood pressure. You know, if you're hungry, your body sends you signals, referred pain. If you have a heart attack, your body sends you usually referred signals. Blood pressure, not so much, but the body itself does monitor blood pressure, and it will take steps to affect or try to affect blood pressure to adjust accordingly. In terms of the regulation of potassium, potassium will affect the resting membrane potential. So we take potassium in and it gets absorbed into the system, and you might excrete it either through the kidneys or through your bowels, you poop or pee it out, right? So you really want to have low potassium in the extracellular fluid, and the intracellular fluid, you want to have high potassium levels. But if you have increased extracellular fluid potassium, that is going to be called hyperkalemia, which will be decrease resting membrane potential, okay? Causes depolarization, we have reduced excitability. It's not as easy to get the signal or the action potential to start. If we have decreased extracellular fluid potassium, this is hypokalemia, which is increased resting membrane potential, which means it's easier to get anyways, we get is easier to get an action potential to signal off. But regardless, if we have abnormal heart potassium concentrations, that could lead to sudden cardiac arrest. Basically, the heart can't contract anymore, sudden death. Now, also, potassium is part of the body's buffering system. So what do we mean? Your body wants to have a certain balance between being too acidic and too basic, pH. And potassium will assist in that. And the way really acidity is if you have these hydrogen ions, so it's a hydrogen atom without the electron. Well, hydrogen shifts in and out of cells in opposition to movement of potassium. So potassium goes in the cells, hydrogen ions come out. If potassium goes out of the cell, hydrogen ions go in. So if you're too acidic, the extracellular fluid will have more potassium. And if you're too alkalosis, too basic, the extracellular potassium levels will fall. But you want to maintain pH within a certain level, otherwise you won't have excitability of cells. Your cells won't be able to send signals and contract and what have you. No, this is just a repeat of the last one. So this is now where we get to pH. So pH, small p, big H, affects all functional proteins and biochemical reactions. So when we talk about acidity, and this is closely regulated by the body. So here are the basics. Let's say you take hydrogen chloride. It's a hydrogen ion or atom and a chloride atom. And if we put it into water, the hydrogen and chloride dissociate from each other. So the chloride separates from the hydrogen, and the hydrogen loses its electron to the chloride ion. So the chloride ion is now negative, the hydrogen ion is positive. But that hydrogen ion is very reactive. So it can then react with other chemicals or other substances within there. And the stereotype is if you have a strong acid, then you stick your, a piece of metal in this beaker and the acid eats away at it because it's all reacting with it. In actuality, a strong acid means that you have a large amount of these molecules dissociating. So because basically in this image, all the hydrogen and chloride ions have dissociated with each other, that is technically a strong acid. And in this case, because only some of the hydrogen ions have dissociated from the bicarbonate ions, this is a weak acid, right? It doesn't dissociate completely. So normal pH of body fluids. So keep in mind that 7 is neutral. It's not acidic, it's not basic. Well, arterial, and the lower the number, the more acidic. Arterial blood is about 7.4. Venous blood and interstitial fluid will have a pH of about 7.35, and intracellular fluid would be a pH about neutral. Alkalosis, right? So your very basic is arterial pH greater than 7.45 and acidosis. So if you're acidic, arterial pH is less than 7.35. So it's a very narrow range within your body. And most of the hydrogen ions are a byproduct of metabolism. And so if you go back to week 3 and think about it, well, the electron transport chain, that makes sense. And then you have lactic acid potentially from glycolysis, and the lactic acid can have a hydrogen ion dissociate. So if you have an increase in hydrogen ions, a lot of the times that will be from metabolism. So just a byproduct of metabolism within the human body. So as we said, strong acids completely dissociate, weak acids do not completely dissociate, or they dissociate partially, and a strong base will dissociate also in water and quickly tie up the hydrogen ions. And a weak base will accept hydrogen ions more slowly. But the concentration of hydrogen ions is basically, it's regulated by 3 mechanisms. Okay, so And here we see listed 3 buffering systems. So there's the chemical buffering system, right? So bicarbonate, phosphate, and protein buffer system. There's also the brain stem respiratory centers, so breathing. And then there's renal. So really, you have chemical buffer systems, you have brain stem, breathing quicker, and then you have renal, which basically means your kidneys, right? So the brain stem will act within 1 to 3 minutes, and renal will is most potent, most powerful, but requires hours or days to affect. Okay, so with this bicarbonate system, it's basically a weak acid and salsa bicarbonate, and basically it'll buffer the intracellular fluid and the extracellular fluid, but is really the extracellular fluid that it works on the most, so the fluid outside of the cells. So if a strong acid is added, the bicarbonate ions, so the HCO3 with a negative sign, will tie up these hydrogen ions and form H2CO3. So the pH will go down slightly unless all the available bicarbonate is used up. And bicarbonate is regulated by the kidneys. So the kidneys will release or absorb HCO3 according to what is needed within the human body. In terms of the phosphate buffer system, the action is basically the same as bicarbonate buffer, and it will use these 2 forms of phosphates to buffer either the acids or the bases. But it's not that great for the plasma system. It's more for intracellular fluid. And then the protein buffer system is basically, it uses protein that can serve both as an acid or a base. So the protein will either be able to tie up hydrogen ions or will be able to tie up bases in order to regulate pH within the body. And so pH really gets a bit complicated, but know the basics that there are the 3 buffering systems, and for chemical buffers, we have 3 chemical buffering systems here. And this is where we start to get to these complicated diagrams, but really this is just to walk you through this and show what's going on. So you have carbon dioxide. So we're going to go to number 1. Carbon dioxide will combine with water within the tubule, and it forms HCO3. And then HCO3 is split. We have a hydrogen ion and we have a bicarbonate ion. The hydrogen ion is secreted into the urine, and the bicarbonate ion enters into the blood, basically with sodium and chloride. So it moves with sodium, it moves opposite of chloride. And then we have the hydrogen ion combines with the bicarbonate and then forms water and carbon dioxide, and basically is released. And if you want more details, you can look, but this is not an area where we're going to really concentrate on. Actually, we'll just skip past this. We get to the good point. So the implications of this is that you may have either metabolic or respiratory issues. You may have respiratory acidosis or alkalosis, so you're too acidic, too basic, right? Acidic, pH too low, alkalosis, basic, pH too high. You have metabolic acidosis or alkalosis. So in terms of respiratory acidosis, impaired lung function, and this is very relevant for COVID because we have an impairment of gas exchange within the lungs. We can't get rid of the carbon dioxide, and we're going to actually, because of that, have a buildup of hydrogen ions within the system. You become more acidic, right? So you could think that if there's an interference, so one concern with COVID right now is that if the body over-responds, we actually see scarification of the lung tissue. We cannot get as efficient gas exchange, and that's impaired lung function. If we have impaired ventilatory movement, so for some reason the person cannot breathe properly, they can't get the volume of air in and out, then that can be an issue where you have a buildup of carbon dioxide, a buildup of hydrogen ions, and the person undergoes respiratory acidosis. The other factor are drugs. So we've had a concern in the past 20 years, 20 years ago, well, not quite 20 years ago, but 15, 20 years ago, when we started prescribing opioid painkillers to non-terminal patients, we started seeing people becoming addicted to these opioid painkillers. And the problem is some of these opioids, when they're sold on the streets, are mixed with very powerful narcotics, fentanyl and carfentanil. Carfentanil is a drug that you would use as a basically to knock out an elephant before you operate on an elephant. What fentanyl, carfentanil do is they depress the respiratory center, so the person hypoventilates, they don't breathe enough, or they stop breathing completely, and then we have respiratory acidosis, and then eventually the person dies from that, unless they're given narcan injection. Respiratory alkalosis, so you become too basic. Well, you hyperventilate. Well, let's say, okay, I'm going to unmute you now, and you're going to present the rest of this to the class. What do? You hyperventilate. You're stressed. You're panic, anxiety. So that can lead to alkalosis. You're getting rid of too much carbon dioxide. You could have also some type of hyperexemia. So, for example, pneumonia. You're at high altitude. You just can't get enough of gas exchange. Or you could have a tumor injury, right? The brain's not functioning properly to control respiratory. Now, metabolic acidosis, so think more metabolic diseases, diabetes being a good example, right? So diabetes, right? Stuff is rushing through the intestinal tract and by secreting it before you can absorb it. So you build up hydrogen ions. Kidney failure, renal disease, right? The body just can't get rid of acids as it should. Starvation, so your body starts to break down proteins and fats, and yeah, you get some metabolites, but you lead to acidosis, and even alcoholism, right? You may get too many excess acids within the blood. Metabolic alkalosis, so you don't have enough hydrogen ions. Well, if you vomit or if you have gastric suctioning, right, you're removing hydrochloric acid. You can also think eating disorders. You could have diuretics. So diuretics are drugs which cause you to lose fluids, but also with that, you're going to lose potassium and lose hydrogen ions. If you take too much sodium bicarbonate, which is an antacid. And a good example is this could hit you on a double whammy. So if you take a lot of antacids, that can absorb all the hydrogen ions within your system and lead to metabolic alkalosis. In the 80s, there are a series of runners who thought, well, if I take baking soda, which is sodium bicarbonate, before a race, that will help neutralize the acids that they build up through metabolism through exercising. Well, the problem is for some of them, they went into metabolic alkalosis, but also for some of them, if you consume baking soda, it actually causes diarrhea. And so that just leads to all kinds of mess and embarrassment. And also if you have, say, a tumor on your adrenal gland, so you have too much aldosterone, you get excessive reabsorption of sodium, which pulls increased amounts of hydrogen ions into the urine, basically leads to alkalosis. So there are clinical implications for this. Most commonly in our industry, what we're going to see is some type of respiratory acidosis or metabolic acidosis, probably respiratory acidosis, because you have a person who's exercised very intensely, at an intensity higher than they want. The pH drops, they've got excess hydrogen ions within their system, and especially if they had a big meal before, they will throw up on the floor and you won't see it coming. So just be careful when you're training your clients at a higher intensity. Also, so the effects of acidosis. So, I mean, really, if your blood pH goes below 6.8, you can die. And if your blood pH goes above 7.8, you can die. So you want to keep the blood pH around 7.35, 7.45, in between that range. But really, if it goes too low, goes too high, you can die. And then symptoms of acidosis and alkalosis: headache, sleeplessness, confusion, loss of consciousness, death, shortness of breath, coughing, arrhythmia, increased heart rate, because remember, potassium ions move in the opposite direction of hydrogen ions, so you may have hypokalemia. That could be a problem. Seizures or weaknesses of the muscle system, nausea, vomiting, diarrhea. Alkalosis, pH is too high. Central nervous system, confusion, lighthead, stupor, coma. Peripheral nervous system, hands are trembling, numbness, You might have muscle twitching, spasms, or nausea and vomiting. So we've kind of skipped over the end of the pH stuff, but we're not going to go too in depth in that. But when you get into exercise physiology in second semester, that's when you really start to get more in depth with pH balance within the human body. So having said that, we are finished for the day.